going to talk about mitral regurgitation assessment, and I guess I'm hoping to finish it up in 40-45 minutes, and then hopefully if there are any questions or discussions at the end. So I might get started. Okay, so mitral regurgitation. I guess in your practice, you are going to see mitral regurgitation present as a primary problem. And when that happens, you might see a very unwell patient who comes in with a pretty bad shock and very hypoxic, very unwell. It's quite an angry presentation. Or you may have MR as a bystander, which may complicate the course of another illness. For example, disproportionate hypoxia in pulmonary sepsis, or you are trying to wean a patient off the ventilator, and you find that there is hypoxia on weaning the ventilator. So it could present as a bystander, complicating your management. Good thing about MR is, as an intensivist, I can do a lot to minimize the hemodynamic impact of the MR. But I guess that creates problem as well, because I can make MR look severe or less severe depending upon changing the loading conditions. I guess the bottom line is to be mindful that MR is very load dependent, and hence it's important to acknowledge what the loading conditions are before assessing mitral regurgitation. So in this talk, I would just talk about how would you go about assessing MR severity and what are the pitfalls in various ways of assessing MR, and then how can it guide the management. Now, I guess when you are asked about assessment of MR, the first thing that comes to mind is what's the severity. But I guess before we delve into severity, the very important question is actually what's the mechanism of mitral regurgitation. And essentially, we are thinking whether the mitral valve, the MR is related to primary mitral valve pathology, or is it a secondary MR due to problems in the myocardium? Because if it's an acute primary mitral valve pathology leading to MR, assessment of severity is less important, because usually that patient needs an intervention straight away. So before you go into severity, it's important to look at what's the mechanism, and whether it is an acute or chronic. And then, as I said before, what are the loading conditions in which the MR was assessed. So I guess when you are looking at the mitral regurgitation and you're wondering whether it is a primary or whether it is a secondary MR, it's worth the 2D appearance in itself gives a lot away. And what you're looking in 2D is basically the assessment of leaflet appearance and mobility, and how the other apparatus, the chordae, the papillae muscles, and the chamber look like. Now, the mitral valve may have excessive leaflet mobility. And when that happens, we usually encounter this in prolapse of flail. You might have heard about prolapse. The leaflet bulges into the left atrium, the leaflet tip still points towards the LV, and the cutoff is like 2 millimeters above the annular plane, the bulging of the leaflet into the LA. So when that happens, it's called prolapse. And obviously in flail, you're talking about the leaflet that is completely free, and the tip is pointing towards the LA during the systole. Now, mitral valve prolapse, I guess it's commonly seen in patients with redundant fibrous tissue. You're talking Barlow's disease, or the degenerative sort of diseases. And flail is usually presents as a very acute MR with quite significant hemodynamic consequences, shock patient. And you can see this is a TOE image with P3 flail. It's most commonly due to ruptured chordae, but it could be associated with ruptured papillary muscle with more severe consequences. Now the leaflet mobility might be just normal, and this is an example where the leaflet mobility is not too bad, but it's because of the perforation that we are getting an MR. And this was a case of endocarditis, starting from aortic valve and sort of encroaching on the atriomitral curtain, anterior mitral leaflet. And you may have a leaflet which is with reduced mobility, and this is classic rheumatic valve with a bit of a mixed mitral valve disease. And you might have heard of Carpentier classification. That's what it tries to do. It classifies the mitral valve abnormality based on the leaflet mobility. It's not a perfect classification because I mean, there are some pathologies which are difficult to classify, such as your SAM related to asymmetric septal hypertrophy, for example. It's quite difficult to put that in. But mostly your primary mitral valve, primary MR might be because of prolapse of fifth flail, which is like in your excessive leaflet motion category, type 2. Or it could be type 1 with, as we discussed, normal leaflet motion. There's classically perforation, or it might be just restricted, such as in a rheumatic mitral valve disease. Now, secondary MR, where the problem is the underlying myocardium, and the classic problem is that the leaflet gets tethered or pulled towards the apex, which restricts its mobility, and obviously then there is an impaired coaptation of the leaflets because of that. And this is a classic example, is a inferolateral ischemia, and most commonly we see posterior mitral leaflet involved. And because the posterior leaflet gets tethered, you get this end to side configuration of the leaflets and MR jet which goes posteriorly. This is most common sort of phenomena that we see in secondary MR. Now you can classify, I guess, the coaptation and measure coaptation based on these various measures. Some labs do it, we don't do it, because all these coaptation height, coaptation zone, they correlate very poorly with the severity of MR. I guess it might be of some interest to regarding assessment for mitral clipping, but this is not something we routinely do. Now, the other question that is going on in my mind is whether it is an acute MR, and a clinical context is very important in this assessment, because obviously if I'm dealing with a situation or clinical context where the patient presents with a acute onset shortness of breath and hypertension 4 days, 5 days after a recent MI, that makes more sense of acute MR. And having this suspicion and idea of clinical context is very important, because your conventional methods of severity assessment do not apply, and echo assessment is generally very challenging. Now, clinically, these patients present with shock and pulmonary edema, and the left ventricle that actually looks quite hyperdynamic without much MR signal. So that's the challenge. The LV and the LA size are normal, and in contrast to chronic MR, the normal size and the lower LA compliance results in a sudden and severe rise in the LA pressures. And hence, there's a rapid equalization of pressures and low transmitral pressure differential. And moreover, the jet is frequently asymmetric, which is harder to quantify. And also, invariably, these patients are very tachycardic, hyperdynamic, desperately trying to maintain the forward cardiac output. If you can identify pulmonary vein flow profile, that's quite helpful to classify, identify a significant MR, but often that's very difficult, as you know, in transthoracic echo. And I mean, as I said before, just a detection of acute MR in itself is enough to proceed to urgent intervention based on the etiology. And really, you don't go down the route of severity assessment in these patients. I mean, this is one example we had many months back, where he was transferred to ICU with pneumonia because he was short of breath. He had unilateral infiltrates, and he was obviously given antibiotics and transferred, and this was the echo. Nothing much, but he had cold peripheries, which was not in keeping with this echo, where the LV actually looks hyperdynamic, and eventually had a toe, and we found this P3 flail with a ruptured chordae that I showed you before. So having that suspicion is key, and low threshold to do a toe in these patients, and understand the challenges of doing toe in these patients because they're very sick as well and will need an intubation most likely. There are some of the etiology which may lead to acute MR. This ruptured papillary muscle post-MI is one of the ones that we have seen before. Ruptured chordae, leaflet destruction due to endocarditis, and rarely, I've not seen this one, rapid onset cardiomyopathies, Takotsubo's, viral myocarditis sometimes can present. So I guess by this time you have an idea that you're dealing with a primary or secondary acute versus chronic. And then I guess if you're dealing with sort of secondary MR or primary MR, but of chronic nature, such as a mitral valve prolapse, then you can go down to a bit more comprehensive assessment of severity. And this is the conceptual framework that I look at. So on a conceptual framework, severity assessment is based on several measurements, which aim to basically answer three questions. How big is the regurgitant orifice? How much volume is moving back through that orifice? And what are the upstream and downstream consequences of this? Now, the orifice can be estimated by calculating EROA, regurgitant orifice area, and studying the vena contracta and coaptation. How much blood is going back in LA can be estimated by regurgitant volume, regurgitant fraction, and left ventricular ejection fraction. I mentioned LVEF because as the regurgitant volume increases, the end systolic volume decreases while the end diastolic volume increases. So actually the ejection fraction should increase. Now, finally, the upstream and the downstream consequences. So you're looking at the LV and the LA size, pulmonary vein flow, which is one of my favorites, and lung findings like B lines and pulmonary pressures and the RV assessment. So let's go through these measurements in more detail using framework of ultrasound modality. I like this structure, especially for writing down in answers. It gives a bit of a structure. These are obviously, there are some qualitative and some more quantitative measures. We'll go through them. So starting with the 2D features. So 2D assessment, you are looking at now, it's quite useful, as I said before, that it can give you clues towards the acuity as well as primary versus secondary MR, just the 2D appearance of the mitral valve coaptation, how does the valve look like, mobility. And also we can look at upstream effects such as LV dilatation due to chronic volume overload, and downstream effects such as LA dilatation, B lines in the lungs, and features of pulmonary hypertension and RV dilatation. Now, all these are important features of severity, although not specific. I must point that it is important to index the LA and LV dimensions to body surface area, especially in your tiny patients, because this would reduce the risk of underestimating the hemodynamic consequences. And also, where possible, biplane measurements or 3D volumes are better, especially for volume assessments and ejection fraction. And it is important to realize that left ventricular ejection fraction, as we discussed before, in MR should normally be high because the blood is going both forwards as well as backwards across the mitral valve. So any ejection fraction less than 60% in these MR patients would be considered as indicative of LV systolic dysfunction. How can you use color Doppler? Well, color Doppler is very useful. You can look at the jet direction, and the direction, whether it is central or posteriorly directed, can give you a bit of a clue towards the mechanism or the etiology. One of the other advantages of this color Doppler is you can make a judgment whether the MR is occurring throughout the systole or only a part of it. And this is a very important assessment because, as you would realize, most of our assessments of the severity are based on a single frame measurements, whether it is a Pisa radius, whether it is a vena contracta, you are making a measurement on a single frame. So if the MR is not holosystolic, only happens on only a part of the systole, such as mitral valve prolapse, then you are clearly overestimating the MR. So having this assessment or judgment, whether it is holosystolic or non-systolic, is very useful before you go down the rabbit hole of doing all the measurements. And I find just a color M mode quite useful in this regard. So here are 4 different cases, and you can look at the highly turbulent MR color tracing. That's the one I'm talking about. So you will notice that the duration of the MR during the systole is variable across the 4 cases, and this happens because your regurgitant orifice area is changing during the systole. Now, it is important to recognize this because if MR is not holosystolic, as I said, then there's a risk of overestimating. In such cases, instead of a single frame measurements, volumetric measurements correlate better with the outcomes, and we'll discuss the volumetric measurements in the further slides. You can see mid to late systolic MRs, which are very common in mitral valve prolapse, where the valve gets a bit more lax towards the end of systole. And the late MR is also seen in SAM, in HOCM cases. Biphasic MR is very common in secondary MR, and early systolic MR can be found in cases with bundle branch flow. Next, next the color Doppler you can use to study 3 aspects of the MR jet anatomy. So when you talk about how what are the different components of the MR jet, there's flow convergence, there's venocontractor, and there's jet area. So as the regurgitant blood from the left ventricle approaches the orifice at the tips of the mitral valve, it forms a convergence zone immediately proximal to the orifice. So this is what we study, the flow convergence. Then the flow traverses through the orifice at a very high velocity, but continues to converge past the orifice to the narrowest point of the jet, and this is the venocontractor. And then, of course, it spreads out into the left atrium. Now, for studying the flow convergence and the jet area, it is recommended to rotate the probe between apical 4-chamber and apical 3-chamber views, trying to maximize the Doppler signal. Venocontractor, I guess, is best in the PLAX because of the axial resolution. Now, as with the jet area, it is recommended to keep the Nyquist limit between 50 to 70. Now, area, as you know, that you can make the area look worse if you reduce your Nyquist limit. And hence, it's important to standardize that Nyquist limit. And generally, if the area is covering more than 50% of LA, then it is considered severe. However, it is not reliable for severity assessment in cases of acute MR, as we discussed earlier, because it's significantly impacted by the driving pressure. It's also not reliable in case of eccentric wall-hugging jets because of that Coanda effect. In both cases, we could end up underestimating MR. On the other hand, we may end up overestimating MR if it's, as we discussed before, if it's not holosystolic or the orifice is like a slit line all across the coaptation. Because, for example, the venocontractor could look very different and the jet area could look very different whether you are catching it in its plane or at the orthogonal plane. So be mindful of that. In my practice, I use the jet in the context of flow convergence and venocontractor, a jet, I guess, which reaches the opposite wall or pulmonary vein and has a large flow convergence, has a thick neck, is likely to be severe. On the other hand, a small non-eccentric jet with narrow venocontractor and no visible flow convergences are likely to be moderate or severe. It's likely a mild MR. Now, for the venocontractor width, less than 0.3 centimeter is considered mild, more than or equal to 0.7 is considered severe. If you are using 3D probes, you can actually measure the width in orthogonal planes, and you can average the venocontractor in the orthogonal planes. I think the British guidelines say that if you are using this technique, then your cutoff should be at 0.8. And now, I quite like venocontractor width, as it is a surrogate for regurgitant orifice area and works equally well for central and eccentric jet and is less impacted by the driving pressures. Now, limitations are that, like many other single frame measurements, it will overestimate severity in a non-holosystolic MR, and also it becomes unreliable in cases of multiple jets. And when the orifice is elliptical in shape, which is commonly a case with a secondary MR, I guess in elliptical orifice, you can overcome this by, as I was saying, you can take the orthogonal measurements and average them out. But if there's emerging data around 3D vena contracta area, which is also a very attractive option in these complex elliptical jets. Now let's talk about the flow convergence. Now, when the flow converges to pass through a small circular orifice, now multiple hemispherical shells are formed of decreasing surface area but increasing velocity. The velocity should, however, be same throughout a surface of a particular hemisphere, and hence the term isovelocity. Now, product of the surface area and the velocity would give us flow rate, and as per conservation of mass, the flow rate should be same across each hemisphere and the orifice. Now, this is the assumption. So we can actually make the we can measure the peak velocity through the orifice using continuous wave. And this way we can calculate the EROA by rearranging the equation. So this is what I was talking about. Now, to identify the flow convergence hemisphere, we lower down the Nyquist limit to 30 to 40 centimeters per second in the direction of the flow. Then freeze, zoom to identify the first hemisphere where the aliasing occurs. The velocity at this obviously will be your Nyquist limit, because that's where the aliasing is happening. And the distance from the neck to the beginning of the aliasing will give us the radius of the hemisphere, and that the machine can use to calculate the surface area of that hemisphere. Now, Pisa radius more than or equal to 1, such as CBR-MR, and Pisa radius can also be used to calculate EROA and recurrent volume. Now, Pisa method has obvious limitation. It can be a bit tricky to judge the position of the orifice. I guess the aliasing is not that tricky, but yeah, where to put your other caliper point at the orifice can be a bit tricky. And not surprisingly, there is a variability of 10 to 20% in operators, into individual operators, while calculating EROA. And this is important because when you use this radius to calculate the EROA, it gets squared. So any error will get squared. So yeah, that's the downside. As we discussed before, the whole Pisa method assumes a circular orifice, and this is rarely the case, particularly in the secondary MR. The orifice is usually elliptical, and hence the Pisa method can underestimate the EROA, and it's important to keep that in mind. And also, it's less accurate in case of eccentric jets, where there may not be a classic hemisphere. And I guess you can use angle corrections for measured EROA in these eccentric jets, but I've never used it. It sounds very complicated, needs software. Certainly, I don't have that on my machine. And of course, you can't use this in multiple jets. And again, remember, it's a single frame measurement. So again, if you're dealing with a non-holosystolic MR, you're gonna overcall it. And that's the angle correction for a non-hemispherical convergence in eccentric jets. Now let's look at the use of spectral Doppler to study MR jet and mitral inflow velocity and pulmonary vein flow patterns. Now, continuous wave has limited value in direct quantitative severity assessment. I guess most MR, you will see that they end up in the same range of velocities, 4 to 6 meters per second. However, it can give clue to the hemodynamic consequences. Now, low velocity may suggest low blood pressure and a high LA pressure, and it can be helpful in assessing downstream hemodynamic consequences of pulmonary hypertension. Like you can measure the TR jet and pulmonary hypertension assessments. Now, however, qualitative assessment is better. looking at the shape and the density can be quite informative. Now, in the severe MR, the regurgitant jet becomes more truncated, triangular, with early peaking instead of the usual parabolic or tongue-shaped appearance. And this happens due to elevated LA pressures and early equalization of the pressures. And also the wave becomes more darker as or dense as more red blood cells are packed together. A handy tip is to just compare that MR jet with the mitral inflow EA waveform density. So if as the MR gets more severe, it will approach the same density as the forward flow, the mitral inflow density. Now, pulse wave Doppler can be used to study mitral inflow patterns. Patients with severe MR have dominant early filling, increased E velocities due to increased diastolic flows across the mitral valve. And we are talking usually almost always E velocities of more than or equal to 1.2 meters per second. If the E velocity is not more than 1.2 meters per second, I wouldn't be interested in assessing for severe MR. An impaired relaxation pattern with a low E velocity and a wave dominant virtually excludes severe MR. However, we cannot interpret E wave velocities, I guess, in the presence of mitral stenosis or other causes of elevated LA pressure. A pulse wave Doppler can also help in calculating regurgitant volume, either by studying the stroke volume method, in which we'll talk about this in the next few slides. And we can use that pulse wave to calculate VTI of forward flow at the mitral annulus, or by PISA method, where we calculate the MR VTI and multiply by EROA to get the regurgitant volume. Now, pulse wave can also be used to study pulmonary vein flow profile, and certainly this is something I'm very keen on looking at in all patients where I'm assessing MR, especially if they are on ventilator and I've got TOE in them. Because why I like this is because it is free from all the assumptions of the jet, excuse me, and the orifice anatomy. So now this is a normal pattern. So you've got a predominant S wave, followed by a D wave and a AR when they have atrial contraction. So as the LA pressure goes up, your systolic velocities go down. And in the severe MR, you start to see systolic flow reversal. Now, the specificity of systolic flow reversal increases if you can demonstrate this on two pulmonary veins. And this is an example where I had an eccentric MR, and it just shows that I had systolic blunting in one pulmonary vein, whereas on the other side, I had a systolic flow reversal. And this is usually the case where these patients have eccentric MR, unilateral pulmonary infiltrates, unilateral pulmonary edema. Now, all the data that we have collected so far can be used used for quantitative assessment of MR severity by estimating three entities: the EROA, regurgitant volume, and regurgitant fraction. And they can be calculated either by PISA method, and this is the most common method. The cardiology lab here almost always uses PISA method. Or you can also use a stroke volume method, and we'll talk about this in the next few slides. As we go through these methods in the next few slides, you will also realize that although they are meaningful entities, there are a lot of assumptions, and measurement errors can creep in, and they get squared. So if you don't have to use these heavily complicated derived entities, that's the best. We'll discuss this in a bit more detail as to how you go about when you've got so much data. How do you make a judgment about the severity? Now, I was talking about using PISA method to calculate these entities, and I guess we have discussed this in the previous slides, how you can use the PISA radius, calculate the EROA first, and then you can multiply EROA with MR VTI to get the regurgitant volume. And then once you have got the regurgitant volume, you can get regurgitant fraction by by comparing it with the stroke volume across the LVOT total stroke volume. So, and this is the stroke volume method. I guess the total, the assumption here, if you're using stroke volume method, you basically calculate the regurgitant volume and then use it to calculate EROA and fraction. So stroke volume method, very simple assumption that the total left ventricular stroke volume should be a sum of blood going forwards, that is the stroke volume across LVOT, and the blood going backwards, that is regurgitant volume. And regurgitant volume, obviously, then you can rearrange and calculate the regurgitant volume from this equation. You can also use the mitral valve stroke volume because the blood which goes forward and backwards should be equal to the mitral valve inflow stroke volume in the previous beat. So you can use the stroke volume across mitral valve, although that's very complicated because you can imagine that, okay, you can get the mitral inflow VTI, but the just getting the annulus, it's a elliptical shape, Pringles shape, and it's hard to quantify the area of the mitral valve. It's not that easy. If you are using a 3D probe, I would suggest you use ultrasound enhancing agents to identify the stroke volume, the total stroke volume, and then you can use, if you subtract the LVOT VTI stroke volume, then that should give you a regurgitant volume pretty much. Now, good thing is, because you are not directly measuring the jet anatomy, this method of stroke volume, using stroke volume method to assess the EROA, it can work in any sort of jet. Eccentric jet, multiple jets, non-circular orifice, and it has been actually validated against these cardiac MRI studies as well. And obviously, there are limitations. This method cannot be used in if you have got an AR unless you are using a pulmonic side, and it's cumbersome, involving multiple measurements and risk of amplifying errors again. And it's not uncommon to get different results from stroke volume and PISA method. Which one do you rely? Now, additionally, you can end up underestimating MR if there is a high LVOT VTI, for example, flow acceleration in SAM, or there is an AR, as we discussed earlier. On the other hand, it can overestimate MR if the mitral valve VTI is high, such as mitral valve stenosis, or if there is a septal shunts. Also, it is quite tricky in AF, as the stroke volume keeps changing at both the sides, and hence it will not reflect the true degree of MR. So there are some challenges with this method. To avoid having to measure the cross-sectional area of mitral valve, as we discussed, it could be a bit challenging because of its shape. And to avoid measuring LVOT area, a concept of regurgitant index has been introduced, which is simply measuring the ratio of mitral valve VTI and LVOT VTI, and a ratio greater than 1.4 is consistent with severe MR. Although it still shares the other limitations of stroke volume methods, such as if you've got AR, increased VTI due to stenosis, position of sampling box, etc. But at least you are not measuring the area, so one error is gone. Now, irrespective of method, here are the cutoffs for MR severity as per the ACE guidelines. Now, discrepancy may arise between these parameters in low and high flow states. For example, despite severe MR, regurgitant volume may be low in low flow states, and regurgitant fraction may be helpful to some extent in these low flow states because its derivation has, its derivation has more errors. Now, after so much data, the question is how we go about putting it all together in the assessment of severity. Now, clearly, we have to rely on multiple measurements. As we have discussed, all measurements have got problems with it. So relying on multiple measurements is probably better. So this approach has been suggested by ACE guidelines and begins by looking for some specific criteria for severe and mild MR. For severe MR, 2D features of flail leaflet, enlarged LV with normal function, color, Doppler jet dimensions of Pisa radius more than or equal to 1, vena contracta, central jet area, and spectral Doppler finding of pulmonary vein flow reversal. For mild MR, the specific criteria of 2D features of normal size, color Doppler dimensions like Pisa, vena contracta, the jet area, and spectral Doppler showing A wave dominant mitral inflow velocities or soft or incomplete MR jet. So these are some of the features that would support the mild MR. So if you've got more than or equal to 4 features, you can go ahead and classify it as severe or mild. So you don't have to thankfully go down the rabbit hole of calculating EROA, regurgitant volume, and all those measurement errors that we were talking about. But I guess if you have got less than 4 features, then unfortunately you have to rely on these entities of EROA, regurgitant volume, and regurgitant fraction. And as I said before, most commonly these will be derived using a PISA method. As we discussed earlier, that PISA method, which is the predominant practice, assumes a circular orifice. And however, almost all secondary MRs have elliptical orifice. So, and so do some of the primary MR as well. So in these cases, there may be underestimation of EROA, and in the light of other limitations, these patients can get misclassified as moderate when they actually have a severe MR and poor outcomes. So for this reason, the decision was made to split this moderate group right in the center and create grades of 1, 2, 3, and 4. And using these grade 3, classifying them as severe if they have elliptical orifice, and you just need 3 other specific criteria instead of 4. Then you classify them as severe, and they are the ones who should be have poor outcomes and may benefit from an intervention. And these days, it's usually you are talking about whether they are candidates for mitral clip. Now, 2 studies in the recent past, the MITRA-FR and the COAPT, targeted the same disease entity of the severe secondary MR with the same device, mitral clip. While the MITRA-FR was a negative study, COAPT showed benefit. Now, the COAPT had more severe MR, but less impaired left ventricular function, whereas MITRA-FR had more dilated left ventricles, and it was a negative study. So I guess you have to select patients who are symptomatic, who are severe, having severe MR, but their LV disease is not very advanced. So what I'm hinting to is this concept of proportionality of MR. So there are clearly patients where there is an MR which is way more severe than you can explain by the left ventricle problems. So obviously this leads to the question whether the MR is too severe for the given LV dysfunction. And how do you approach patients who look like echocardiographically have severe MR, but they are symptomatic? Now, this is not where critical care or intensive care practice would be involved, but this is something I found very interesting. That the concept of proportionality is coming in, and one of the studies looked at comparing the EROA with the left ventricular end diastolic volume, and the ratio of more than 0.14 was thought to be more reflective of patients who would have disproportionate MR as compared to the left ventricular dysfunction. And maybe these are the patients who would really benefit from CLIP. And then, of course, there are some novel indices to catch patients early on, especially when they are not very symptomatic. And we are looking at LA now because the MR, long-standing MR, can cause remodeling of LA. So they are looking at LA ejection fraction, LA strain studies to identify early LA problems and whether these patients should be taken up for early intervention. Coming to the summary, I guess I would like to summarize that the MR severity should be assessed in the context of etiology. You should make an assessment whether it is primary or a secondary MR, or dealing with an acute MR. versus chronic. Be mindful of the loading conditions because it can change the MR quite significantly. Acute MR is challenging to diagnose. These patients present with shock with pulmonary edema and a hyperdynamic left ventricle, which does not explain the clinical picture of a cold, mottled patient. And clinical suspicion is very important. All measurements have significant limitations, and being mindful of that. I have a patient right now in my side in the unit who has got ischemic MR, and the cardiology team looked at the PISA radius of 0.7, but then I was looking at their mid-commissural view on TTE, and there was another jet as well, A2 and P1, which was 0.5, and I was thinking, how do you make sense of this? So being mindful of all the measurements and the limitations, and be careful of those non-spherical orifice, non-holosystolic MRs and eccentric MRs, which are very challenging to quantify, and wherever possible, using volumetric assessments and studying the upstream and downstream effects are quite useful. That's it. Thank you. Hope I'm on time.
Thanks very much for that.
No worries. Any questions, thoughts, experience, comments? Well, thanks, team. You can always get back to me on my email, or I think Tara would have my email contact. So if you have any questions, send it through. Thank you. All the best.
Thank you.
Have a good weekend.
Thanks very much.
Bye.
Thank you.